Welcome back to Oncology for the Inquisitive Mind, featuring your two favourite Australian oncologists, Dr. Michael Fernando and Dr. Josh Hurwitz. Today, Michael and Josh have decided to twin. We are both wearing white t-shirts. Michael has a bull, I have a dog, but we look exactly the same. We're almost like brothers here. Michael, how are you?
Literally exactly the same. And no, we didn't plan this. We're just on the same wavelength. And no, there will be no mention of brands because we're not sponsored by fashion outlets as much as we would like to be. But yes, it is a new episode. And in this episode, we are both wearing white t-shirts. Today's episode is also our second on early gastric cancer. And it has to come with an apology from me because, you know, I have one job on this podcast and it's to line up studies for the episodes. And the first study, the study that I'm going to talk about, which is the FLOT4 study, got a few mentions last week and in retrospect probably should have been done last episode. But hey, I also like to think that I have a life outside of recording. I probably don't, but you know, that is what it is. So if you want to get more of a chronological sense of early gastric cancer development, I recommend watching or listening to the first half of this episode, stopping and then going back to last episode, listening to that one, and then coming back for the second half. And while you're fiddling around with all of that, maybe leave us a review and a rating and a subscription or whatever. I figured I'd get that out of the way, Josh.
Yeah, that was actually perfect timing. Or just ask us a question. I would also like to hear from you if you want to hear something on this very roundabout podcast, as it's turned out on as of recording a Thursday afternoon.
Thursday morning / afternoon. But yes, if you have any particular questions or particular studies that you're just dying to have subjected to our ham-fisted analysis, then please send them through. I think the email is at the end of every episode, so you have no excuse for not knowing our email address off the top of your head.
And I can also share Michael's mobile number for free. You just let me know.
Which will be completely useless for people outside of Australia, unless they want to incur massive international calling fees, which we do not endorse or recommend, it must be said.
All right. Well, we've crossed all of those things off our list, Michael. Crossed. See what I did there?
Yes.
Why don't we just start?
Which is ironic because Cross is one of the studies we're actually not talking about, Josh. But we'll good try. We'll give it to you.
Thank you.
No, the study to which I was referring earlier in a very roundabout way, but this show could be renamed the Oncology Roundabout podcast or the Oncology Roundabout. If we ever need a rebrand, Josh, that's a good name for it. The study that I will be talking about here is the FLOT4 AIO study. And this was a study done in the late 2010s, 2019 to be precise. And it's an interesting study to talk about because it does form the basis of pretty much all of our treatment of early gastric and gastroesophageal cancer. And as we saw last week, now esophageal cancer, now that Cross has been sort of relegated very much to the people who are more frail and less likely to tolerate perioperative therapy. The background to FLOT4 AIO, which I'll just call the FLOT4 study from now on, is that prior to this, the largest study to demonstrate a benefit for perioperative chemotherapy in the gastric and gastric esophageal junction was the MAGIC trial. And MAGIC stands for Medical Research Council Adjuvant Gastric Infusional Chemotherapy Study. One of those studies that you feel like someone just wanted to call their study MAGIC and then worked back from there. In MAGIC, there were 503 patients with resectable esophagogastric adenocarcinoma that were treated with 6 cycles of ECF, that's epirubicin, cisplatin, and 5-FU. So 3 neoadjuvant and 3 adjuvant. And this was compared to surgery alone, and it showed that there was a benefit. The next development of this was the DCF regimen, which is docetaxel, cisplatin, and 5-FU, but this was associated with significant toxicity. And now this is how we come to FLOT, because what the lineage, you might say, the genetic lineage of FLOT, is that they took DCF, but instead of cisplatin, they substituted oxaliplatin and then modified the doses so that it was every 2 weeks as opposed to every 3 weeks. And there were several phase 2 studies that demonstrated the improved tolerance of FLOT over DCF, but FLOT4 AIO was a phase 2 2/3 trial that aimed to compare perioperative ECF or ECX, ECX being ECF with capecitabine instead of 5-fluorouracil, with perioperative FLOT. The phase 2 results were published in 2017, which demonstrated that FLOT was superior to ECF in terms of pathological regression. Pretty bad numbers, let's be honest, 15 versus 6%. But this was statistically significant, so hey, important. But the overall survival results, which for, as we have spoken about in the context of breast cancer and lung cancer and any cancer really, are the gold standard for any adjuvant or early cancer study, were published as part of the phase 3 component in 2019. So 716 patients were enrolled in this study, and it was an investigator-initiated, multi-center, randomized, unmasked controlled trial. I guess it's a bit hard to mask your study when one of your agents is, I'm assuming, bright red, epirubicin. I mean, that would kind of ruin the blinding, wouldn't it? Key eligibility criteria for the FLOT4 study were histologically confirmed gastric and GOJ adenocarcinoma, so that's all squames out. Clinically stage T2, node positive or both, and they had to have obviously no evidence of distant metastases. As we can see from the consort graph here, patients were randomized 1-to-1 to receive either perioperative ECF, ECX, depending on the clinician's choice, or perioperative FLOT. Patients were stratified according to the ECOG performance status, 0-to-1 versus 2. The location of the primary tumor according to the, I'm going backwards, the SEWIT criteria, and I've got a slide here just in case you need a refresher if you're watching this on YouTube. So it just depends, or the SEWIT criteria basically determines where the tumor has arisen from, with increasing type basically meaning further distally in the alimentary tract. So the higher the type, the further into the stomach that you are. The outcomes for the study were, the primary study was, let me try that again. The primary endpoint was overall survival. I will get there eventually. With the secondary endpoints being R0 resection rate, disease-free survival, surgical morbidity and mortality, and adverse events. It's worth noting as well that the initial primary endpoint was disease-free survival, but this was changed upon request of the, and I'm quoting here, the Independent Scientific Committee of German Cancer Aid. And I want to be in a room with the German Cancer Aid Society that has the power to change primary outcomes on studies. It sounds like an organization with incredible power and influence.
I was going to say efficiency.
Well, I mean, yes, if we're going to lean into stereotypes here, that sort of goes with being German, doesn't it? Just incredible efficiency. So I've made Josh uncomfortable there, which is a nice change of pace because normally it's the other way around. So just
first time for everything.
First time for everything. So in terms of the demographics, a couple of demographic notes here. So there was a male predominance in the study, about 75% in both arms, which fits with the standard pattern of gastric cancer incidence. Most patients were ECOG 0. The majority were less than 60. I should say that the highest single age group was less than 60 years old. It was 44%, so not technically a majority. Similarly, the majority of patients had gastric primaries, and the majority of patients had T3 primaries, and 80% of patients were node positive. So it's not like in this study they're selecting the small tumors that are likely to do well, shall we say. I guess in the context of oncology, you want treatments to work for the more aggressive or the more advanced tumors. I thought that in talking about the results, we talk primarily, or first I should say, about tolerance and treatment delivery, because Josh, I don't know how much FLOT you've used, but in my experience, it's quite difficult to deliver in terms of side effects, and particularly in terms of the adjuvant as opposed to the neoadjuvant component.
Well, I will talk about that when I discuss my trial, but I might just reiterate what you're about to say.
Yeah, look, probably. So in terms of the study, you have 91% of patients in the ECF group and 90% of patients in the FLOT group completed all cycles of preoperative chemotherapy. And this tracks with our practice at the moment, that the preoperative or neoadjuvant component of this regimen is easier for patients to get through than the adjuvant. In terms of patients who completed all allocated cycles, 37% in the ECF group and 46% in the FLOT group. So less than half of patients in both arms, almost a third of patients in the ECF group were getting to the ends of their treatment. And 21% of patients in the ECF arm and 34% of patients in the FLOT arm received GCSF at any time point, which I also thought was interesting because, again, I don't know how it is where you work, Josh, but in the place where I work, the hospital where I work, it sounds like I work in a back alley somewhere, but in the hospital that I work, Josh is nodding sagely, I do work in a back alley. GCSF is built into the protocol. So you go into the program, you order the FLOT pathway, and lipofilgrastim is preloaded into that. So I thought that it was interesting that there was a fairly low uptake of GCSF in the study. In terms of early discontinuation, 21% of ECF and 13% of the FLOT group discontinued due to either disease progression, lack of efficacy, or early death, which I thought was pretty grim. 17% of patients in both arms ceased treatment due to patient request, and 13% of patients in the ECF group and 10% in the FLOT group ceased due to toxicity, which means that 4% in the ECF, 4% of patients in the ECF arm and 7% of patients in the FLOT arm stopped, or the patients requested to stop due to a reason other than toxicity or due to intolerance, which again is interesting. Similarly, so significantly more patients than in the FLOT group received tumour surgery, 94% versus 87%, and this was statistically significant despite similar rates of patients proceeding to surgery itself. And I'm assuming what this means is that for a significant proportion of patients in the ECF group, the surgeons went in with the intention of doing a resection, opened them up, saw that the cancer was either not resectable or had progressed on treatment, and then closed the patient back up without removing the tumour. That's how I'm interpreting that. In terms of toxicity, there were higher rates of grade 3 and 4 nausea, vomiting, and VTE and anemia in the ECF group. Stands to reason, given there's an anthracycline in there. But there were higher rates of infection, neutropenia, diarrhea, and neuropathy in the FLOT group, which again stands to reason, given the platinum you're using in these regimens is oxali for FLOT. Much higher or much greater association with peripheral neuropathy, and cisplatin in the ECF group, which has a lesser incidence of peripheral neuropathy. Severe adverse events were similar in both groups, and there were 2 grade 5 events in both groups. Also similar postoperative complication rates and similar duration of hospital stay and deaths within 30 to 90 days. And you're probably sitting there listening or watching to me blather on and thinking, Michael, this is all very interesting, but is FLOT any good? Or is it at least better than ECF? And the answer, as you can see here, if you are indeed watching, is yes. So the R0 resection rate for FLOT was higher compared to ECF, 85 versus 78%, and this was statistically significant. There were higher rates of YPT1 tumours in the FLOT group compared to the ECF group, and I'm assuming the way this was written in the study is that this was at the time of surgery, because they say YPT1 as opposed to clinical tumour grade. So you would assume that represents a higher rate of tumour downstaging. There were also higher rates of pathologically node negative cancers in the FLOT arm, 49 compared to 41%, again at the time of surgery. As you can see here, the overall survival rate is higher in the FLOT arm compared to the ECF arm, 50 months compared to 35 months, with a hazard ratio of 0.77. And I just want to point out and say that 50 months for an early stage cancer gives you a hint of how difficult gastric and gastroesophageal cancer is to treat. Interestingly, the upper limit of the overall survival in the FLOT arm was not reached. 45% compared to 36% of patients were estimated to be alive at 5 years, and when they adjusted for stratification factors, the hazard ratio was unchanged, so that's important. And then finally, the disease-free survival was 30 versus 18 months in FLOT and ECF, respectively. And as you can see from this forest plot, it was beneficial in most of the arms. So that was the FLOT study. And this is really why, and it's taken me 15 minutes to get to this point, that this is why perioperative FLOT is the standard of care in early gastric and gastroesophageal cancer. Thank you for coming to my TED Talk.
Is that going to be your TED Talk, Michael, in 20 years, reviewing a trial from 15, well, it'll be like 35 years beforehand?
It would be interesting to see the reaction, because most TED Talks I feel are like, if you give someone a hug every day, then your oxytocin level's going to go up and you'll be more productive. It
kind of love
really,
that.
it wouldn't really fit. I mean, your oxytocin, Josh, should be sky high because you just go around giving people hugs whether they want them or not.
Well, I feel like I should have to say on this podcast that consent is important and is mandatory. And mandatory no means no. Michael, you're just really doing it today. I might move in and look at a different peak if that's okay.
A different peak. And which peak would that be, Josh?
Matterhorn. I
almost blurted it out.
Almost. So I'm talking about the Matterhorn trial, which got us a standing ovation last year at ESMO, or maybe it was ASCO. But to sort of build on what Michael said, we know FLOT is now the standard of care, perioperative. We know people struggle with adjuvant, but there is still really high recurrence rates, even with R0 resections and downstaging and adjuvant chemo. It's one of the gastroesophageal cancers and gastric cancers are one of the leading causes of cancer deaths worldwide. While curative surgery and chemo is sort of the standard of care, the recurrence rates after resection can sort of be up to 50%. So still really high. FLOT4, as Michael said, is now the standard of care. And it's better than the CROSS trial, which we've done previously, and better than the MAGIC trial before that, which Michael has also spoken about previously. But this trial is looking at the addition of immunotherapy to FLOT. Giving immunotherapy in the perioperative space, will it improve outcomes longer term? They realize that maybe there's a signal because it's all been approved in the metastatic setting, and that will come in 1 or 2 episodes. So stay tuned if you're liking what we're doing. And so that's sort of where all this came from. And just a little bit of interesting, Matterhorn, Michael, the Matterhorn mountain. It's a mountain in the Alps. It straddles the main watershed and border between Switzerland and Italy, and its summit is 4,478 meters above sea level. It has been described as the most beautiful mountain in the world.
See, this is why I love doing this show with you, Josh, is because I learned so much. I just thought that the Matterhorn was a ride at Disneyland. Is it also that? I don't know.
I've never been to Disneyland. Maybe when you go, you can tell me. That's. Really,
I genuinely
really
don't know. That's the association I have with that word. But now I know it's a real place and that it is the most beautiful mountain in the world.
You're the most beautiful mountain in the world.
All mountains look terrible compared to Matterhorn. Oh, you're very sorry.
That's fine. So looking at the study design, it was a phase 3 multinational double-blind randomized placebo-controlled trial involving stage 2 to stage 4A and those that are eligible for surgical resection, good ECOG status, no prior chemotherapy, good EGOT performance status, with the primary endpoint being event-free survival. And the secondary endpoints being, the main ones were overall survival and pathological complete response, and other ones including disease-free survival, surgery R0 section. There are some other ones that haven't been reported on just yet. And so I think stay tuned with regards to that as to when we find that out in later episodes. There's some interesting stuff to chat about. I actually wrote this on a slide because I felt it's worthwhile talking about. There's about 1,200 patients enrolled, about 474 patients in each arm. It was randomized 1-to-1. Median follow-up was about 31 months. When we look at completion of treatment, and Michael already spoke about this, in the durvalumab and the placebo arm for that specific component, most patients completed treatment. For the neoadjuvant FLOT, again, about 94 and 92% completed treatment, and then about 85% in each arm, a little bit higher, a little bit lower, but I'm averaging that out, had surgery. When you look at adjuvant FLOT, about 3/4 in each arm started adjuvant FLOT, but those that completed was about 50% in each. So you lose about half of your cohort giving adjuvant therapy. And that's huge. Subsequent therapy, 23% in the development group and 32% in the placebo group. This is the juicy part, which I always say. This is the event-free survival, and I think that's where people actually want to see what happens. When you look at the efficacy of this, so about 32% of patients in the development arm and 46% of patients in the placebo group had disease progression or died. And 30 and 37% respectively died from any causes. At 18 months, so there's a couple of time points I want to check out for you, 18 months and 24 months. EFS was pretty similar at 18 months, but at 24 months, actually that's a lie, I made a mistake. EFS was better at 18 months, so 73% versus 63%. And then at the 24 months, it was 67% versus 58%, with a hazard ratio that was statistically significant of 0.71. EFS has improved, and in those who had complete response, major pathological response, and any pathological response, it was the hazard ratio in the durvalumab arm was 0.29, 0.32, and 0.60 respectively. So pretty significant stuff. This is just a little forest plot looking at also the sub-analysis, and as you can see, everyone sort of trends towards the durvalumab arm being better. There's a couple other really interesting things, and I will talk about it because I know we've been talking for a long time. Overall survival. This was also statistically significant. So at 24 months, 75% of the durvalumab arm and 70% of the control arm were still alive. The restricted mean survival time, or RMST, was 37.6 months, and I think there was a difference of about 2 months there, or 2.2. And then there was an update given about 6 months later after this publication in the New England Journal of Medicine. So that was about June, July 25. And then in December, they had an update. And so they found there was a benefit irrespective of PD-L1 status with a hazard ratio of 0.79 for overall survival. And that was statistically significant. So we know that giving durvalumab in the perioperative space improves overall survival irrespective of PD-1 expression, which is spoken about at least 215 times, Michael, based on every episode we've ever done on this podcast, that PD-1 is not a great answer for response. Pathological complete response was about 10% higher in the durvalumab arm group. And so that's really sort of the interesting part. And then R0 section was pretty great in both arms, about 91 and 92%. In the R0 section space, the 24 months disease-free survival was about 10% better in the durvalumab arm. The other things to really show is to talk about safety. Safety is something that we like to talk on this podcast because it's difficult to really, give everyone an answer and be like, oh, this is a great drug. But look, durvalumab is pretty well tolerated. It's like any classic immunotherapy. You have your immunotherapy-related adverse events. And what they found is that grade 3 or 4 events were essentially the same between both arms, which is reassuring that adding durvalumab within this cohort of patients was good and didn't really influence practice from an adverse events profile. Its common side effects for FLOT were as expected: diarrhea, nausea, neutropenia, alopecia, decreased appetite. And the last slide I will have up is just showing that difference in overall survival and showing that difference in pathological complete response of that 10%, or it's 12% really, 12% benefit. So the summary for this trial is in the gastric and GOJ space, adding durvalumab should be your standard of care. It is still not perfect, but it is a step like everything we see with immunotherapy in the right direction. It raises some really interesting questions about, given that there is still a massive recurrence rate, and there will still be a recurrence rate in this cohort of patients, what do you do? Do you re-challenge the immunotherapy? Do you just look for HER2 therapy? Are there sort of other options for what is a difficult cohort of patients to treat, and also a frail and morbid population, knowing that 50% can't complete adjuvant FLOT?
I think we said about MATTERHORN at the time when we had James McCracken on our episode, which was incidentally a great episode. A great episode. You should go back and listen to that one. That it's great that MATTERHORN the gastric cancer got a Guernsey at the international conference. I think it was ASCO.
It was, because it was June.
When it came out, yeah. So yes, a couple of things about this study that give me hope and optimism for the future of gastric cancer is that the primary endpoint was EFS as opposed to overall survival. And the fact that overall survival hasn't, I think, completely read out yet shows how far we've come in the management of early gastric cancer. If you think about the FLOT4 trial, overall survival was the primary endpoint. The other thing as well is that I thought that the FLOT arm, so the placebo arm in MATTERHORN, did actually quite well. I noticed that in terms of EFS, the upper limit wasn't reached for the FLOT arm. And I do wonder if that means that we are, in the 6 or 7 years since the FLOT4 study came out, that we're just better at administering and delivering the treatment. And that means that people have better outcomes if we're giving more treatment. But it is interesting to see some of the differences between these studies when there is a significant time period between them. But yeah, I think MATTERHORN, if you can get immunotherapy, perioperative immunotherapy, much like with Niagara and urothelial cancer, use it.
Yeah, exactly. And Michael, just to flag, I don't mean to correct, because I know you've probably done far more gastric cancer recently than I have. The OS did read out. It read out 6 months. It's read out 6 months after the initial MATTERHORN. So that's where the OS was 0.78. So look, 22% better. I'd take my chances with that.
Yeah, absolutely. And as you said, the addition of immunotherapy is not really moving the needle in terms of toxicity, except
which I love.
The small number of people who have the severe toxicities, but that's another conversation entirely. Well, Josh, thank you. That was a fantastic episode. And I don't think we've mentioned this, but I believe this is also our 200th episode. How about that? We've been doing this for 200 episodes and no one has yelled at us to stop.
No, not yet.
Not yet. So I think that that is a wonderful piece of news. Thank you very much for listening or watching for 200 episodes. And here's to 200 more, because we will never run out of stuff to talk about.
Never.
Thank you. And next time we'll be advancing to the advanced setting of gastric and GOJ cancer. We hope to speak to you then.
Bye.
Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.